All right, hi, it's Katie Wiskar from UBC IM POCUS. This is another pathology video. Today we're looking at cardiac views and specifically apical 4 and 5 chamber views and some pathology from these images. As a reminder, these videos are intended to give you a sense of what abnormal looks like because often we learn these techniques when scanning normals, but it's important to get a sense of what is not normal so that you can identify it when you see it in your patients. Okay, starting off with a normal just to get you situated. This is an apical 4 chamber view. So left ventricle, left atrium, right ventricle, right atrium. And LV systolic function looks quite normal here. We see normal looking myocardial excursion and thickening. RV size looks quite normal. RV shape looks normal. RV function, if we're visually looking at TAP-C, and that lateral annulus of the tricuspid valve looks quite normal as well. In contrast, so this is another apical 4 chamber view. We've lost some of the apex of the heart, and you do see that sometimes you'll get a bit of ultrasound dropout in the first few centimeters. So in really thin patients, it can be hard to see apex. But even just from what we can see from the walls of the LV, they're really not moving. They're really not thickening very much. The RV function also looks to be severely depressed if we're paying attention visually to TAP-C. So how much is that lateral annulus of the tricuspid valve bouncing up and down? And it's really not at all. I also am visually just looking at that mitral valve for LV systolic function and saying, it doesn't look like it's opening that well. You can't measure an EPSS from this view, but sometimes just that lack of valve opening can give you a clue as well. So I would put this one in the severely reduced camp, so an EF less than 30%. This is another normal, so a less good image than before. Again, we've got some apical dropout, so we're not seeing the apex of the heart very well. But visually we can see, from those walls of the LV that we can see as it's contracting, it looks like the walls are moving together fairly well. It looks like there is some thickening, although because it's not a great image, we don't see the myocardium super well. The RV size also visually looks fairly normal. I'm kind of extrapolating here from the part that I can see. And visually, TAP-C looks like it's moving up and down fairly well. This is a fun color image. So there's a whole video on color Doppler. I encourage you to watch it. Blue is not venous, red is not arterial. This is just a matter of directionality. So blue is blood going away from our probe, red is blood going towards our probe. So what we can see here in this apical 5 chamber view, because we're seeing the aortic valve and the aortic outflow tract in view, is both the red jet of aortic regurgitation coming back up towards the probe, as well as a blue jet of mitral regurgitation going back down through the mitral valve into the left atrium. The blue that we're seeing coming down the left ventricular outflow tract, that's normal. That's normal to see that blue outflow flowing out of the LVOT. So the abnormal part is the red coming back up towards the probe. That's your AR. We also have note, if you're paying attention to contractility here, see severely reduced biventricular function. This is an impressive apical 4 chamber view. So the first thing to do if you see a view like this is to make sure your probe isn't flipped, because the right side of the heart looks much bigger than the left side. And recall that normally the LV should be bigger than the RV. The RV, in fact, should be no more than 2/3 the size of the LV under normal circumstances. So we've confirmed that we're not flipped. We're in cardiac convention and our indicator is pointing towards 3 o'clock. And we have a huge RV here, clearly bigger than the LV. So this is severe RV dilation. We also see that the RV size is shape is abnormal, So instead of being small and triangular and crescent shaped, it's become kind of big and ovoid and it's taken over the apex. The right atrium is also enormous here. And you can just kind of appreciate how people run into trouble and how it get hypotensive from RV failure, because look at how small that little left ventricle is. There's just no blood in there for it to eject. So even though the LV function is probably normal, the issue in this heart is not at all the LV. It's that the RV is failing and can't get blood over to the LV, and it's also squishing the LV. So the LV doesn't have room to accept enough blood to generate a decent cardiac output. This is an apical 4 chamber view. Again, LV here, RV over there, 2 atria looking fairly normal in size. And our RV looks pretty decent here. The size looks fairly normal. Again, we're not really seeing the apex, but it doesn't look more than 2/3 the size of the LV here. And The lateral annulus of the tricuspid valve seems to be moving up and down okay. What's abnormal here is the LV systolic function. So although the heart is going fast, there's really not a lot of movement of myocardial excursion, the walls coming together. And we also don't really see much thickening. So this is probably severely reduced LVEF. This is an apical 5-chamber view that's quite normal. So recall to go from apical 4-chamber to a 5-chamber view, what we're going to do is going to fan up to point our beam more up towards the patient's head to bring out that LVOT and the aortic valve. And we see the LV, the walls look like they're coming together decently well. We don't see the myocardium super well. So some of this is, with experience, you'll learn what looks normal and what's not normal, even in these suboptimal views. The RV looks pretty normal in terms of size and shape. TAPC visually looks pretty normal. So this is a fairly normal heart. This is some more color. Again, blue is blood going away from the probe. We have left atrium, left ventricle, RV, RA. And the impressive finding here is that blue jet of blood going back through the mitral valve into the left atrium. So this is mitral regurgitation. We would call this eccentric MR because it's going off to one side. It's not central. It's not going down the middle of the valve. And again, valves are complicated, and I'd encourage you to watch the dedicated videos, and calling something eccentric also has implications in terms of valve function. So it's not something to take lightly. But in this case, this is what we see. We see this jet of blue MR kind of wrapping around that lateral side of the left atrium. This is another really impressive heart. Again, one where you check to make sure your probe isn't flipped. But we see huge right ventricle, so severe RV dilation. We call it severe when the RV is bigger than the LV. Huge right atrium as well. Reduced RV systolic function. Visually, we can look at that TAPC and also at the RV free wall movement are the two things we look at for RV function. And we see that the RV chamber size isn't really changing as the RV contracts. And the lateral annulus of the tricuspid valve isn't really moving up and down very well. So severely reduced RV systolic function and severe dilation. So this is a very unhappy RV. This is an apical 4-chamber view, kind of an RV-centered apical 4-chamber view. So normally in our apical 4-chamber views, we want the LV centered on our screen with the apex kind of right in the middle and the left ventricle centered there. And part of the reason why we're sort of off axis is the RV looks dilated here. Again, it's hard to get a great sense of this. We've got some rib shadow in the way, but it looks like the RV is kind of taken over the apex here. And what supports that is the fact that we're also seeing severe TR. So severe TR is often a bystander in right heart disease. As we put our color here over the tricuspid valve, and we can see this big blue jet going back into the right atrium. We call TR or MR severe if they hit the back wall of the atrium or if they occupy more than 50% of it. So we would call this severe disease. This is a really impressive echo image. We've cut off a little bit of the bottom of the atria, but the obvious impressive thing here is the left ventricle and this really dramatic ballooning of the apex. And you can even see some swirling of blood there. So we see that sometimes when there's really stagnant blood flow, and you can see how this would be a risk factor for example, LV thrombus and clot formation. So this is an example of Takatsubos. This is the classic morphology, apical ballooning and preserved basal contractility. This is an apical 5-chamber view because we see the aortic valve and the aortic outflow tract there. It's not a great quality view, but what you might notice is there is a white thing attached to the aortic valve that is not normal, that looks to live on the ventricular side but kind of fling into the outflow tract as the valve opens. So this is a vegetation. Thrombus can actually look similar. Both of these will be mobile hyperechoic structures attached to the valve that have independent movement. So context is important in helping you tease out that distinction. This is another apical 4-chamber view showing severe biventricular dysfunction. So we see that both the LV as well as the RV seem to have severe dysfunction. So on the LV, we don't really see the walls contracting very well. We don't see any thickening. The mitral valve is opening minimally. With the RV over there, although its shape appears normal, The visual TAPC that I'm looking at, that lateral annulus is just not bouncing up and down very much. And I also don't see the free wall coming in very much. Those are the two things I look at for the RV. This is a fun picture. So this is an apical 4-chamber view, kind of RV centered again, because our LV apex is not in the middle of our screen, our RV is. We see some RV dilation, because certainly from this view, the RV looks bigger than the LV. And the really abnormal thing here is obviously this mobile hyperechoic stuff in the right atrium kind of going into the right ventricle. So this is a terrifying image. This is clot in transit that you might see in a patient with PE. So call your PERT team friends, your critical care friends, if you see this. This is a really impressive image. We'll have another video about pericardial effusion specifically and kind of recognizing that, but this is an apical 4-chamber view showing a large kind of pericardial effusion there above the apex. And we also actually see a little bit of sort of fibrin stranding within the effusion. It doesn't look totally simple. There's kind of some little stringy lines there. We also notice as we're paying attention to the RV here that there might be some chamber collapse. So some atrial systolic collapse and some RV diastolic collapse that we'll talk more about in our pericardial effusion video. Okay, that's it for these views. Thanks for watching. Again, check out the tutorials for more on how to acquire these images and some details about what we look for when we're quantifying, for example, LV or RV function. Thanks.